the position. We're stabilising the bite, restoring the bite, and then stabilising it posteriorly at that bite. If you do it the other way around, you get into trouble. Now, the other thing that we do a lot of is the transition of patients from teeth to implant restorations. So fixed and removable implant restorations. And that's a really big part of what I do. I work with quite a few surgeons, and we do a lot of work in hospitals, immediate loading, transition to full arch restorations. And I really like that kind of dentistry too. The fixed and removable restoration, so it's not necessarily the big glamorous fixed stuff. Sometimes maybe overdentures, and especially in elderly patients or medically compromised patients, they work beautifully. And then I used to do a lot of TMD and occlusion. I actually don't do very much of it at all now because I have a couple of guys that work with me who really like that stuff. So I won't talk about that today. I'm going to play through it. Here we go. Now, when you ask a sales rep or a dentist what the success rate of dental implants is, they always give you a number. What's the number? 95%, yeah, 98%. It depends on kind of what literature you're reading. But implants of all parts of dentistry have the highest level of litigation. And if they were successful 95, 98% of the time, you wouldn't expect that to be the case, would you? When we talk about 95, 98% of the time, we're talking about pure integration. So when you put an implant in the bone's going to grow and lock you in place. That's usually not where people get in trouble with implants. If an implant fails, in fact, patients are usually accepting of that, you take it out, put a new one in. Not a big problem in the overall scheme of things. It's when it's not planned right or doesn't come out right. That's when patients get upset. And that comes down to treatment planning and an assessment of the patient sometimes. So we're talking here about kind of risk assessment for patients. So let me share a couple of stories about difficult patients. Yeah. Now this patient, this is a long time ago now, I'm trying to remember the story. This patient came to see me having had the teeth removed. He was encouraged to have his teeth removed and immediate dentures. And he came to see me but not wearing his dentures, which is always a problem. Sometimes the problem here is the patient acceptance of loss of the teeth. And that's, I think, the challenge that we had here. All he said he wants is a set of dentures he can wear, definitely doesn't want implants. So we can do some complicated dentistry with dentures. We can do kind of very specialised impression techniques, a neutral zoning technique for putting the teeth in the right position. We can use really fancy teeth, we can custom stain them, and we can make really kind of pretty dentures. But in the middle of this, he's instituted legal proceedings against the previous dentist. He doesn't want to wear his new dentures because he thinks they look too real. He feels he won't adapt to them, and he doesn't leave the house because of depression and self-image. Now, can I have predicted this outcome? Yeah. And do you think implants are going to solve that outcome? That's a patient acceptance problem. So it's a patient who needs management more than what I can offer in the dental clinic. Especially needs treatment with a psychologist for the impact of loss of teeth on his life. And the obvious thing here is to say that we need to give him implants because he's going to have fixed teeth again. But from experience, the patient in this situation doesn't cope well with complicated dentistry. So the solution is not more dentistry. The solution is just take a step back and look at this patient and look at what's happening. And then try and coax them through and help provide them with the support they need in other realms before we start more complicated procedures. Now this is another one. This lady was very young. She was 30 and lost her teeth through carers. Now she had depression and was on multiple medications, xerostomia, lost the teeth. And that is a not that uncommon story. I mean, it's uncommon for her age, but it's something we see not that uncommonly. And she came in wanting her teeth back, doesn't want to have to remove them. And we went through a stage of using fixed implants for her. So we use a lot of fixed implants in young patients when we need to. I'm not a big advocate of taking out teeth to put implants in. I think if we can keep teeth in young patients, that's definitely the way to go. But if someone is young who's a dentalist or can't keep the teeth, then they usually do much better with something more like what they had. Whereas an elderly patient, I'm more inclined to do something removable because it's going to be easier to maintain, look after over time. So this patient we planned for fixed implant restorations in the lower. This is the procedure, and you've probably all seen some of these pictures or similar pictures. This lady had so many antibiotics when she was little. That's part of the reason the teeth didn't work very well, that the bone was quite stained. So she had guided surgery. This is called an alveolectomy guide. So we put the, this is quite a long time ago now too, we put that guide over the bone. We cut the bone off to get rid of the skinny bit, because we don't want to put implants in the skinny bit of the anterior mandible. And then we have a second guide, so you can see the depth cuts here. A second guide that fits over the top, and then guided surgery to place those 4 implants in the mandible. And we're able to immediately load these. This is again an analog technique, it's a really old picture, but we can, on the same day of surgery, suture and then attach a pre-made denture into this process and give her teeth that she can function with pretty quickly after the procedure. So let me grab some water. So these days we do this quite differently. We do it with scanners, and we do it with lab-made prostheses that are milled, and it comes out, they're really, really nice. But the purpose of this story is to tell you that this patient had, really high-end top dentistry, but still had problems adapting to it. So there's nothing, we probably would have done differently with the dentistry, but she says, I don't feel like her teeth, I want to take them out, but I can't. And had this image of, this kind of grief self-image of loss of her teeth. She also couldn't wear shoes because she didn't like the feeling of the shoes around her feet. She could only wear Ugg boots walking around. So there's complicated psychological things that happen here with loss of the teeth. And picking up these patients before we get into complicated dentistry makes a big difference. The challenge with implants is if you look at the patients we use them on, they're often what we call maladaptive patients because we're kind of selecting for those patients. So when we used to make a lot of immediate dentures, there are studies like this, and they say that if you made immediate dentures for 100 people, about 10 to 15% of them would really struggle. Has everyone had that experience? When you transition someone from teeth to dentures? And there's a group of people that just can't cope with that transition. They're called maladaptive patients. Now, implants work very well in those patients, but we're selecting for the patients that are going to be tricky. Does that make sense? Because they're the ones that haven't adapted well to the previous treatment. If you have a very adaptive patient who uses implants, they adapt beautifully. So implants are a tool to help with these patients quite often. So let's take a step back now and look at why we'll use implants. We always like to define our goals. And the goals are usually that we're trying to provide an aesthetic and functional tooth replacement that survives in the mouth for a clinically useful period of time, that justifies the cost and time associated with treatment. Now we use this when we talk about any restorative treatment in the mouth. We might use it for a post-in-core restoration, for example. In a post-in-core restoration, you've got a 16-year-old who's broken their front tooth off, and the tooth is borderline restorable. I'm much more inclined to keep that tooth, even if it's only for, say, 5 years, even if it's going to take a bit of treatment to do that, because that patient's not really suitable for an implant at this time. Why wouldn't a 16-year-old be suitable for implants? Yeah, you're worried about continued growth. Because when you put an implant into the bone, the implant was never going to move. The teeth will grow, so the teeth will continue to grow, but the implant's going to stay where you put it. What age do you think we start using implants in the anterior maxilla for patients? 25 is a really conservative estimate. Yeah. Any other ideas? When would you be happy to start that process? Does it depend on a few things?
Male,
Yeah. So in when you look at growth studies, it's a very good thought. When you look at growth studies, males tend to grow later than females. That's the growth spurt phase. But females tend to grow for a longer time than males. So the typical one that gets in for a position is actually a female, because they grow for a longer time into their, say, early 20s in the face. That's what the studies show us. So most of the time, if I have a 16-year-old with a loss of a tooth, we're not talking about implants. But if I can keep a tooth, I definitely would like to do that, and that justifies the time and cost associated with treatment. If we have a 20-year-old, then I'm looking at weighing up those options. Yeah. So sometimes we'll do implants in patients who are 20, 21, if they fulfill a couple of requirements. And one is that they have finished growing essentially. So there are some ways we assess that, but most commonly we work with an orthodontist who'll help us with those kind of things. But it depends on how aesthetic it's going to be. Because the longer we can wait for, the more likely it's going to be stable over time. Someone with a low lip line, for example, if the other teeth grow and it's 1 millimetre in for a position, then we just replace the crown. It doesn't make a lot of difference. Yeah, but someone with a really high lip line, central incisor, we try and wait for as long as possible. And we might use a bonded bridge for another 5 years, for example, to get them to that stage. We also like to think about when we're planning, what are the alternatives to implants here? Because it's easy to jump into that implant track. So if we've got a tooth that is borderline restorable, we've always got a few different options. And let's compare them. We'll look at the literature about the outcomes for those options. So if we have a tooth that's pulpless, like this one, it's had a trauma and lost part of its crown. One option is to root treat that tooth, do endo and restore it. We rarely do this. We rarely take out front teeth and don't restore them these days. We'll often use partial dentures, but usually that's tried to be a stepping stone. Yeah. So these days we prefer, wherever we can, to have fixed restorations where possible. Because patients like them better, they need much less maintenance, more comfortable, better quality of life. The downside is they're a bit more expensive, a bit more involved to do. So you're all good at having this discussion, I'm sure, when someone comes in, you talk through those different ideas. The next option is to have a single tooth implant. The advantage of a single tooth implant is you've got separate teeth. This is how I explain to patients all the time. So if something happens to one of them, we manage one of them. Whereas if you link them together with a bridge, we're linking teeth, we're putting more load on the abutment teeth. And if something happens to it, we're retreating the three of them. So if we look at the outcomes for those different studies, this is a very strongly powered study. What that means is that we talk about a hierarchy of studies. Case reports is obviously low hierarchy. The highest level of study is the meta-analysis of reviews. What they do is they take all the other studies, take all the numbers, all the patients out of those studies and put them together. And this is an example of a systematic review meta-analysis of all outcome data for these different techniques we're talking about. So they took 143 studies, they brought them together, and they classed them by the duration of the study. I'm only talking about 6+ years here because most things last for a couple of years. So let's look at the slightly longer term aspect of those studies. And then what we're comparing is the outcome of endo treatment versus single tooth implants versus bridges. If we look at the outcome of endo treatment versus single tooth implants, because that's a common decision we've got to make, there's not a lot of difference between the two. The difference comes down to this word, which is success versus survival. Everyone, I think, has heard this discussion about success and survival. Success for an endodontist means that they have finished the endo, they've watched it heal, they've put the periapical radiograph under their microscope and looked for an area. They're trying to look for a tiny kind of disruption of that outcome. So it's a very specific definition of success. That's why I think this number is slightly lower than this number. Because survival for an implant means you tap on the top of it and it makes that ting sound. When we account for that difference in the definition, I think the outcome these days of endo treatment versus implants is essentially the same. And that's that 95, 98% we're talking about, definition we were talking about before. Now, what would lead you to keep a tooth for a patient then? Why would you keep the tooth and not just take it out and put an implant in every time? Yeah, well, what are the pros of keeping the tooth?
To delay the implant failure eventually.
Yeah, so age of the patient is a really good one. Yeah. So if they're a young patient and I can keep the tooth, I think that's a really good thing, especially if they're too young to have an implant, but also if they're in their 20s, 30s, because any dentistry we're going to do is going to need to be retreated over time. And if I take out a tooth and put an implant in now, chances are in 10, 20 years, we might need to do it again. And if we do it the second time, it's going to be harder than it's done the first time. So if we avoid starting that restorative cycle, then we're going to serve that patient better throughout their life. So if I've got a tooth that's restorable, predictably, like it's got to be restorable, you know, we're talking about the strength of these teeth, then my preference is to keep that tooth where we can, unless it disrupts the rest of the treatment plan that we have. So I don't agree with the electively taking out teeth and making a full arch bridge, which is done often, yeah, because I think that's not a great service to patients sometimes. I think we've got to keep as many teeth as we can and do conservative dentistry, but good quality dentistry. That's what I think the goal should be. Now, what's the advantage of an implant over a bridge, for example? When might you choose one or the other? What would you talk to patients about? Yeah, that's a really big one, yeah. When are you worried about prepping the adjacent teeth? Yeah. And what about the teeth? Yeah, if they're intact teeth, that's not good dentistry these days. So we rarely do bridges where we've got to prep intact teeth. Or if they're vulnerable teeth, the same thing is true. Yeah. So if they're teeth that have been root-treated and have posts in them, and we're then going to attach a bridge onto them, I don't think that's great treatment planning either if we could plan an implant in the middle. But sometimes putting a bridge on is good treatment planning. When might we use a bridge instead of an implant?
Medical compromise manipulation.
Medically compromised, yeah, so kind of surgery, that's a good idea, yep. What's an example of a medically compromised patient?
Maybe uncontrolled diabetes, probably.
Yeah, so bisphosphonates is a really big one. Yeah, uncontrolled diabetes, yes. Obviously you try and control the diabetes, yeah. Yes, so anything that's going to affect the surgical outcome would obviously drop the success of implants. And we may prefer to do a bridge in that case. Anyone else? Yeah, where the implant's going to be complicated. So yeah, you're right, if there's a need for a sinus lift or some complicated grafting to put the implant in, then sometimes a bridge is a useful treatment still to do. So there are pros and cons of all these different treatment approaches. But the important thing from this slide, I think the important thing to take home from it, is that the outcome of endo treatment and single tooth implants when they're done well these days is probably the same. Yeah. Some things are easier to do keeping a tooth. So where's an example of something that's easier to get a nice outcome if we kept the tooth rather than taking the tooth out? Can anyone think of something like that? Where's it easier to make something look better if we keep a tooth? Yeah, anterior maxilla. If we can keep the tooth and put a crown on the tooth, it's pretty easy to make it look nice, isn't it? But to make an implant look nice in the anterior maxilla takes a lot of, sometimes complicated dentistry. So again, keeping that tooth is what we often would do. So where we can, we keep the tooth. If we can't, we've got implants as a really good alternative. The success rate of a bridge, though, is quite a bit less. So a bridge isn't really our first port of call for replacement of a missing tooth, unless there's a good reason that we can't do the other ones. That's, I think, what we should be thinking about with implants. Now let's look at how and why implants fail then. Because we know that most of them succeed, but what causes problems? I always talk to patients about kind of an early or a late failure. They always ask, how long is this going to last you? Is it going to work? Now, an early failure is something that happens in dentistry or in implant dentistry, not uncommonly. Like, it happens sometimes, yeah. And it doesn't really affect the outcome that much. It's inconvenient. That's what an early failure is. A later failure is much harder to recover from. What's an example of an early failure that might happen within the first, say, 3 months of placing the implant? Failure to integrate, that's the most common one, yeah. So the process would be, patients have the implant placed, looks like it's healing well, come back at 3 months, we test it, we find it's loose. Yeah. What do we do? Take it out, let it go, put another one in. Yeah. So in terms of doing that, it's an inconvenience, but it hasn't really affected the long-term process. Yeah. A late failure, the definition of late failure is after the implant's been restored. So an early failure is just failure to integrate the implant, typically. A late failure happens anywhere from 4 or 5 months when it's restored to 5 or 10 years. What's an example of a late failure, or how do implants fail once they're already restored? So, yeah, so there's kind of 2 processes there. Yeah. When we talk to patients, we try and make things simple. Yeah. So we're talking about something happens with the gums and bacteria. What might that be? Periimplantitis. Or something happens mechanically. Yeah, which is fracture of the, loosening of the screw, fracture of the implant. Yeah. And all those things are a bit more complicated to manage because the patient's already finished the implant treatment and now we're going to go back to the start. They've kind of paid for the whole process. Yeah. And they're the ones that you've got to kind of manage well. Yeah. There are 2 things I say that are bad for implants after the implant's integrated and restored. Yeah. One is the bugs, that's periimplantitis. And the other one is overloading or the bite. Yeah. So they're the 2 ways that implants tend to fail, and I'll talk to patients about that. We talked about prevention at the start. That's the key to managing these. Is that when we talk about implants, we talk about that early failure to integrate, not a big deal, take it out, fix it, put another one in. Then we talk about a late failure that happens. We talk about 2 things. This is why the patient needs to be monitored over time. So a late failure can happen if we don't clean the implant. Because plaque builds up, implants can get periimplantitis or gum disease like teeth can. We talk about implants being slightly more susceptible to gum disease than teeth are, and the cleaning around the implant has to be better than teeth. That's why I tell patients at the outset. I say, if you're not going to floss all the teeth, just floss your implants. Because we want to keep that gum really, really healthy. There's a different barrier around the implant than there is around the tooth. And if you get periimplantitis, it tends to be more difficult to manage than periodontitis, and quicker than periodontitis. So they need really good monitoring, maintenance, and preventative care. And the other one is the bite. Why do you think the bite could be an issue over time? What happens with implants and teeth that might lead to mechanical problems in implants?
It's a refracture.
Yeah, so that's the outcome. What might be the reason why a screw might fracture?
Grinding.
Grinding? Yeah. So I've done this implant crown. I've put it in. I know the bite's good now. What can happen over time?
Super eruption.
Yeah, the teeth can move, can't they? Yeah. So an implant that's put in the right place and not overloaded when I put it in can be overloaded in a year's time because implants never move, the teeth do. So that's why we need to do something in our yearly review to check for overloading. Because overloading causes all those mechanical complications that we're talking about. What have you guys been taught about occlusion on implants? Tell me how to prevent overloading. What do you typically do? Yeah.
Make sure it's not in ideally not lateral excursion if you can.
Yeah.
Make sure that it's kind of just clear of the occlusion in ICP, and then when they clench it holds should
Yeah.
stop.
Yeah. Yeah, cool. So that's called implant protective occlusion. That's the umbrella name to all those things you're talking about. So essentially what it means on a simple level is that when you bite on a tooth, it'll intrude. And it has a shock absorber in it. It'll intrude by 100 microns, which is 0.1 of a millimeter. But an implant doesn't have a shock absorber. So when you bite on an implant, it's going to be, it's not going to move, it's going to take the force. In fact, if you set up your occlusion so that in light contact, all the teeth touch, including your implant, and then they clench, the force is going on the implant. Does that make sense? Because it doesn't have a shock absorber, and it's not moving down like the teeth are. So we try and put the tooth in implant protective occlusion. That means that when you lightly close, it's not going to touch, but when you clench, it's going to touch. Essentially, it's 100 microns out of contact. Yeah. So that is the thickness of articulating paper, normal articulating paper rather than shim stock is usually about 20 to 40 microns depending on the brand. But that really thick blue one, that's about 100 microns. So you want it to be not overloaded to reduce the incidence of those mechanical complications. And then we want it to be in centric contact, so up and down contact. It's the same with posterior teeth. When we set up an occlusion, the posterior teeth are designed to take the up and down force. The front teeth are designed to take the side to side force. So I don't mind having some side to side force on an implant in the front of the mouth, but I don't want side to side force on an implant in the back of the mouth. In fact, if you have implant or any force side to side on posterior teeth, you're more likely to get cracks or mechanical complications with your implants, cracks in teeth. But there's a type of failure that we don't talk about when we talk about that early and late failure. And it's this kind of failure. What do you think's happened there? That implant's integrated. If you tap on it, it's successful. But it's not a successful patient outcome, is it? Yeah. So can someone describe what the problem is? Yeah. Yeah, so to go back a step, what's the patient complaining of? Yeah. Yeah, it's not a nicely set outcome because you see the metal. And if that patient had a high lip line, that's a terrible outcome, isn't it? Yeah. Now we look at this, that's the implant crown, that's the abutment, that's the implant. Is there a restorative way of fixing that problem? No, is the answer. Yeah. Because we can work with, we put ceramic abutments on, we can change shapes, do all sorts of things. But if the implant itself is exposed, then that's obviously something that we can't change. Now, would soft tissue grafting help us? Not usually. Yeah, it's not really worth the attempt. So if someone came in like this, saying I've had this implant placed, it looks like this, then my recommendation is we take it all out and start again. What causes this problem? What surgical and positioning techniques have caused that problem? Yeah, so the implant is two buccal. Yeah, yeah. And it's either was placed two buccal and always looked like this, which is probably not likely. I think the dentist would have noticed this if it looked like that when they put it in. Or the bone's resorbed as part of that process. Now, when does bone often resorb quickly? Say again? Before that. When does bone often resorb quickly in the mouth in general? When you take a tooth out. Exactly. Yeah. So what do you think the likely cause of this would be? Yeah, it's probably placed immediately and too buccally. That's the highest risk for this kind of problem. So immediate placements are a really technique sensitive and complicated part of dentistry because the outcome, unless done really carefully, can be quite unpredictable. And what we definitely don't want to do is to have the implant too buccal. Yeah. They used to think when you did an immediate, you put the implant in and you wanted to contact the socket the whole way around because you wanted to kind of fill the socket. That was the original protocol like 20 years ago. But we know that part of the bone, which is called bundle bone, see that first, have you heard of bundle bone? Yes. The first 3 or 4 millimeters of the buccal plate gets its innervation from the PDL and will resorb quite predictably after you take the tooth out. So put the implant in the socket against the bundle bone, that's the outcome. We don't want that to be the case. So if we do an immediate, where do we put the implant? More palatal. Yeah, and what do we call the space in between the implant and the bone? Does anyone know what that's called?
Jump gap.
Jump gap, that's right, yeah. And what might we put in that space?
Bone graft.
Yeah, something that's non-resorbable to try and prevent this outcome. And what else might we do to change the soft tissue outcome at the same time?
Tissue grafting.
A soft connective tissue graft, yeah. So the protocol for immediate now, when we do a single tooth immediate, is the tooth will come out, implant goes palatal. There's a jump gap that is usually, we put some non-resorbable bone graft in, and there's a connective tissue graft that's tucked under the gingival buccal. I can show you an example. But that tries to prevent this kind of outcome, but that's not something you can retrieve later on. Now, these are examples. These aren't my cases. These are just ones I've picked off randomly. But are these surgical or prosthetic failures? Yeah. And tell me what might be happening here. What's happened here? What's that? That's the implant. Yeah. The problem is that these ones are placed too shallow. Can everyone see? Yeah. So it's hard to see from the back of the room, but that's the implant. That bit is the small connector, like the abutment, and the rest of it is porcelain. So when the implant itself is exposed, we can't come back from it. Yeah. But the problem is that those implants should be much deeper than where they are now. There's a rule of thumb for how deep you should place an implant. Does anyone know, have you been given rules of thumb? What do you think what's your rule of thumb?
3 to 4 millimeters below the desired gingival.
Yep. Yep. And what about buccopalatal?
2 millimeters.
Yeah. Yeah. So 3 down 2 in. That's a good. That's where the shoulder of the implant should be. This one is pretty much 0 and 0, isn't it? Like it's way too shallow. Yeah. And having an implant too shallow limits what you can do restoratively. One of the things we talk about quite often now is the emergence profile of implant restorations. So the emergence profile is where the restoration goes from the implant to the bit that emerges from the gum. Yeah. And there's a school of thought now that should be within 30 degrees of the long axis of the implant. What we don't want is a mushroom style crown. We don't want to go up and then out like this. Because if we do that, you can't clean very well around it, you can't probe very well around it, and we find that the soft tissue outcomes are much worse. So if you have a smooth contour, smooth emergence profile, then that's much better. Now we can't get a smooth emergence profile within that protocol if the implant's too shallow. So it's got to be deep enough to do that. Now this is a similar process. Imagine that could be an abutment, it could be the crown itself. Let's call it, the problem though is that the implant is too shallow. And this one, who'd like to describe that one? Yeah, is that restoratively driven? Yeah, so it's just placed wherever the bone is, yeah. And again, it's way too high, way too buccal, so you can't come back from that position. There's surgical failures. So when we talk about how implants fail, they fail through the things we spoke about initially, but the biggest factor that patients will tell you about why they're unhappy with their implants is how they look when they're finished. So we talk about aesthetic failures, which an aesthetic failure can be with the white aesthetic or the tooth-coloured aesthetic. That's not such a big deal, because I can manage it. In fact, it's much easier on implants than it is on teeth. Why do you reckon that is? If I had a patient with a single central and it's not bad, and I put it in, is that easier to come back from it if they come back and say they don't like it, but on implants or teeth? Implants. When you unscrew it, send your lab, they tweak the colour, put it back in again. If it's on teeth, what are you going to do? Cut it off and start again. Yeah. So it's actually much easier to manage these white appearance problems on implants than it is on teeth, because you can retrieve them, you can modify them and play with them. The pink aesthetics is much harder on the implant. So the pink aesthetics is the gingival aesthetics. On teeth, the teeth and roots typically support the gingiva, so it's easier to get a finger set. But on implants, because they're trying to trick nature, we've got to do a lot to make them look like natural teeth. Let's look at this design and tell me what the problem with this design is.
Ridge hand.
Yeah, so it's got a ridge line. Yeah. Why do you think it has a ridge line? The implant's too shallow. Yeah, so we've been talking about that. That's good to pick that up straight away, because this position. Now I could fix the ridge line by moving that down to here. What's that going to do there? It's going to look ugly, isn't it? Yeah. Because that position is the fixed part of your implant restoration. So that's the buccal zenith. Yeah. And if you move that, then it's going to look funny. So we've got to put the implant in relative to its position of the buccal zenith. That position, that 4 and 2 you were talking about, or 3 and 2, is much more important these days than the axis of the implant. They used to place implants for screw axis really palatable, really deep. We don't do that as often anymore because we've got much better techniques for managing the screw axis. I'll talk about that later on. Yeah. But what might be an example? How do we manage a screw axis problem? Yeah, it's pretty easy. Angulated screw channels. We can use the screw that goes around the corner and put the implant in a better position. So we reduce risk by selecting appropriate cases. And we call this the risk assessment. That's the idea of the lecture this morning. So we talk about patient factors, surgical factors, and restorative factors. Now the patient factors is all about managing expectations. Because patients always want it to be perfect, but then they understand how many procedures it's going to take to get perfect, and they say, actually, let's look at something we can do more simple sometimes. But it's a matter of managing what it's going to be like when they finish. That's not to say that every implant's going to be terrible, but it's about explaining the steps taken to get to the outcome that they want. Then we have surgical factors, and ideally the surgical factors have a lot of input from the restorative dentist. Yeah.
Talk about the expectations.
Yeah.
At that, they expect that implant is going to last forever.
It's true. Yeah, yeah.
How do you manage?
Sure. Yeah. So at the outset, so not at the end of the procedure. Like talk about this before you start restoring the implant. I would say they always ask how long it's going to last. Yeah. I would say when you put an implant into the bone, 98% of the time it'll take into the bone. So there's an early failure that happens sometimes. Not a big deal. We take it out, put another one in. Yeah. Once it's in the bone, then it needs maintenance over time because everything will wear. And everything will need ongoing preventative maintenance. When I put the implant into the bone, I want that implant to last many, many years. Yeah. There are two things that will affect that. One is bacteria. So if it's not cleaned, the implant can get gum disease. It happens not uncommonly. Yeah. And it needs to be monitored, so initially every 6 to 12 months, to make sure we pick up early signs of peri-implantitis. So the patient knows they're onto this, that they've got to keep that clean. In fact, the surgeon I worked with last night said he tells patients that when he puts like metal restorations in their mouth, he wants them so shiny you can see his reflection. But the other thing is that overloading. I say that if the other teeth move, the other teeth will change. So if the implant's overloaded, then something can happen to it. That can be something small, like the screw can loosen. It can be something bigger, like the screw can break. It can be something really big, like the implant can break. So these things happen to implants over time. I don't want that to happen anytime soon. Yeah. I say, on average, when we put a crown in the mouth on a tooth, we want that crown to be there for, say, 10, 15 years. Implants are similar. Yeah. But things happen. Often they'll last much, much longer. If you look after it, it can last much, much longer than that. But it needs maintenance. That's how I have that discussion. Does that answer your question? Yeah. And surgical factors, this should be restoratively driven. So if you're working with a surgeon who places your implants, I think it's really important to give them really clear indications of what you need. Because they have different kind of goals they're working towards than what we do. And unfortunately, it's the restorative dentist that manages most of the complications. And then we have restorative factors, which are very easy if this is managed well, but very hard if it's not. I'm going to go through, actually, yeah. One of the ways I talk with patients about this is kind of using a traffic light system. So we're talking about an individual tooth prognosis. And what it means is that patients can see what's happening. So if someone comes in, I used to do it on OPG, now I do it on a scan with markers and things. But we'll get a pack of highlighters out and we'll say, these teeth are good, these teeth are okay, these teeth are not good. And we'll put it on the OPG and we'll put it on the model. So we can see, for example, in this case, she's going to lose all her back teeth. She's got really severe xerostomia caries. We've only got a few front teeth that aren't pretty well positioned to work with. So if we're looking at a patient like that, we're looking at just replacing the back teeth, or there's enough yellows there and reds to consider doing a full arch restoration for her. The way we assess risk, what the IGI have recommended is this risk assessment tool. Has anyone seen this? It's very good. If you log on, I'm pretty sure it's free to use still. You can do a checkbox test of how complicated a case is likely to be. So let's use this as an example for assessing which patients have a good level of risk managing our practice. So what it gives you is a simple, advanced, complex scale, like a traffic light system, green to red. Obviously, if you see some complex levels, you know this is a complex case. You think about the skills you have to manage it and think about whether it's best that you manage it or a specialist might manage it. There are general risk factors, there are surgical risk factors, and then there are prosthodontic risk factors. Let's look at some examples. And you can, if you're doing only part of this, you can just kind of cut it down to the part that is relevant for you. The first thing we're looking at is the type of restoration we're doing. Is it a single tooth? Is it a short span bridge, extended span bridge, a removable case, or is it an edentulous case, upper or lower? Obviously they go from simple to complex. The more involved the case, the harder this process will be. I'm going to flick to that one. Now one of the course outline requirements was we talk about what is involved in a single tooth restoration. I'm going to use this as an example talking about a case. For a successful single tooth restoration. So we'll go to the first one of those list of outcomes. This is the list of things that we need. The first thing we need, when we're going to restore a single tooth implant well, is we need to know what type of implant it is. It's already been placed. And we need the correct coping. Don't overlook that. So sometimes we might have an implant come in that we don't know what it is. Has anyone had that experience? And you've got to kind of do some sleuthing. Sometimes you can work out what it is or get the notes from a previous dentist. Sometimes you just can't. So you've got to try and kind of retrofit and work out what type of implant it might be. I'll show you an example of a case where this was done incorrectly. But I'll go through the rest of the things first. So the next thing we want is that impression coping, which has to be the correct one, has to be seated correctly in position. What happens if it isn't? So we're talking about the impression coping putting onto the implant. Yeah. What happens if it's not seated correctly? What's the end outcome? Yeah, so the crown will be made on incorrect information. Now, if an implant impression coping is not seated, that's the usual problem. It's usually not seated and rotated. So when your crown is made, it's made thinking the implant's here, not here. So the crown will end up being twisted and short. Does that make sense? Not by much. It's probably the height of the hex of an implant, because usually X-hex implants, this happens to like 0.7 millimeters. But it might be twisted a bit because it never sat on the hex properly. How do we stop that from happening? Yeah, we take a radiograph with the impression coping in place to check that the piece is seated correctly. Yeah, so we do that, as often as we can. The next thing that we need to have recorded is the position of the implant relative to the teeth on either side. We need to get the contacts correct and the aesthetics correct. We need to know the position relative to the opposing teeth to get the bite correct. We need to record the soft tissue profile. And then we need to have clear instructions for our lab on the shade, design, materials that are going to be used as we make this restoration. That's kind of a checklist of things we need for a single tooth implant. Let's look at what happens if we get one of those wrong. So here, where are we? This one. Yeah. This patient came in, she was referred by the surgeon who placed the implant because the crown has come loose like 5 or 6 times. And the dents were tightened up, the crown would come loose, tightened up, the crown would come loose. So something's happening there, isn't it? So once we worked out what the problem was, the implant, the right X-ray is with the problem fixed. Can anyone see what the difference between the two is? This crown is the same. Yeah, yeah. So what can you tell me about this screw versus the other screw? So it's longer, yeah. Now watch, when you take an X-ray of an implant and you look at the screw channel, should the screw touch the bottom of the channel? What would happen if it did? We call that bottoming out. Yeah. So the way screws work, just to kind of explain that, is that you have obviously a thread inside the implant and a thread on the screw. Now when you tighten it, it's stretching the screw. Yeah. So it has to be able to freely tighten to the required torque, so we get enough stretching of the screw. And that stretching of the screw is called preload. If the bite force exceeds the preload, it'll come loose. That's how mechanics of screws work. So you need to be able to do it up without impinging on anything. If you're doing it up and it hits the bottom, what's your preload going to be? Nothing. There's no stretching of that screw. Does that make sense? Yeah. So here, they haven't used the correct componentry. It's an X-hex implant. It's actually a Southern X-hex implant that has a, what we call a coaxial, does anyone know what that is? Yeah. The head's offset. So it uses a special screw. But they used the generic X-hex stuff, which has a longer screw, and that meant that this kept loosened. So all we had to do was to change it to the correct screw with the correct length, and it solved that problem. It hasn't come loose since. So first step is to know the correct implant and the correct componentry that we need. The other challenge is that what happens when you do a screw up 5 or 6 times? You strip the head, especially if you're trying to tighten it every time. Yeah. Does anyone know how to get the stripped head screw out? Yeah, so what's that picture? That's the screw out, so I've obviously taken it out. What do you think I've done to the top of that screw? Does it look normal? Yeah. So here, this should have, the other trick here is that there are 2 types of screws use different drivers. So they're using the wrong driver and tightening up a lot. So they've stripped the screw inside here. So there's nothing for the hex to engage. So to take out that screw, we've cut a little slot on either side, and then we've used a flat driver to engage that, to be able to undo the screw and take it out. And that was the difference between the two. This is the screw that we should use. That's the screw that was in there. And because it's an off-axis implant, the screw channel is shorter than it would be otherwise. So know what implant it is, use the correct componentry for the type of implant that it is, and try not to guess. Like if it looks like something similar, find out for sure. So we've done single teeth implants. The next step is a short span bridge. When we have a short span bridge, we've introduced another couple of layers of complexity. Yeah. One of those layers of complexity is you've got 2 things and they've got to fit together really precisely. So we want to get what's called a passive fit. if we don't have a passive fit, we've got an implant crown that doesn't fit properly, then either when we put it in, there's going to be a space. That space is going to be at the implant level, right next to the bone, filled with bugs. Not good. The other thing that happens is if you tighten down the screw really hard, you're going to try and force it into place. You're going to set up a lot of unwanted stress within the system. So you're either going to lead to a breakage of the screw or loosening of the implant or breakage of the restoration in some place. So when we've got two implants together, it increases the complexity because we've got to make that fit and that fit. On teeth, when we make bridges, what makes this easier? Are we as worried about passive fit on teeth? Not so much. Cement is one thing, but it's movement of the tooth, that's the other. So has anyone had experience where you've gone to make a bridge, you've taken your temporary crowns off, you may not have had a temporary bridge, you may have had two separate temporary crowns. You put it in, and there's like a tiny gap around one of the abutments. And you're like, damn. What do you do? I don't think that's the kind of right thing to do because it won't adapt in the way you want it to usually. What you do is hold your thumb on it. If you hold your thumb on it for about a minute, that tooth has enough movement in it that it's going to sit back to where it was before. Use not very much movement. And that, cobalt chrome frameworks, when you put them in, they feel like, it's almost there but not quite there. And they come back a week later and it looks perfect. Because teeth adapt. Yeah, no, you try not to do that, but these things, we know teeth adapt to those changes. And as long as you haven't cemented it in place, you can use the bridge just to kind of help it to seat to where it needs to. You can't do that with implants, because implants are never going to move. The fit you have on day one is going to be the same as the fit you have many years later. So we have a short span bridge, it gets harder. The connections get a bit harder too. Right, talked about that. Here we go. So the additional challenges when we're talking about splinting implants together is that there's no flexibility, so we have to be much more accurate. A single tooth implant restoration is much easier than taking a single crown restoration. Yeah, once you get the hang of it, because your margin is already set with your impression coping. You're just picking up the position. But a multiple unit implant restoration is harder than doing crown bridge. If we don't have the correct we don't have the correct componentry, or we make it so that there's a slight discrepancy in the fit, then that defect is usually at bone level, which is where we don't want the defect to be. We also have unusual challenges compared to teeth because we have to think about how the mechanics work. So the easiest way to imagine this is we'll go back to, I've got a picture here, yeah we do. Back to using X-Hex implant just to understand this, then we can adapt it to other implants too. We have two types of connections when we use an external hex implant. This is the original implant, the one that Brunnemark used to use many, many years ago. And the idea is that it's got a hex over the top, and that hex orientates all your pieces. If it didn't have a hex, everything would spin around. That make sense? Yeah. So when you put an impression coping on any system now, you rotate it around till it pops, clips down. Yeah, it may not click, it'll kind of sit down into that position. We call that engaging, because the hex is engaging the components. If we have, so on a single tooth restoration, you always need to have some kind of engaging element. If you have a multiple unit restoration though, and you have engaging elements, what's the problem? So the engaging element is super parallel. Now think about what the problem might be. Are the implants usually super parallel? Yeah. So what happens if you've got something like this and something like this? And we're trying to put something over the top of it. It won't see. That make sense? Yeah. Because the engaging parts are super parallel and super precise. But what's the engaging element there for? Why do you need a hex inside an implant? I'll give you a clue. To stop it rotating. Yeah. If you've got 2 implants, is it going to rotate? No, because the engaging part is provided by the other implant. Does that make sense? Yeah. So when we have 2 implants next to each other, we don't use what we call engaging componentry. We use non-engaging componentry. Has anyone heard of non-engaging componentry before? What it means is that we don't use the hex. So the bits that you buy don't have a hex inside them. They're like smooth. Yeah. Now you put 1 on, it'll spin around, but you put 2 on, it'll sit down properly and screw in place. So if you're doing multiple unit restorations, you've got to think about what's going to, which type of componentry we can use. Now this is true of all implants. All implants have this engaging or non-engaging system. We get around it in different ways. So X-hex implants will often splint together at the fixture level, which means splitting them at the implant level. But some implants have a cone type connection. Yeah. And the cone will still have an engaging element at the bottom of it. When we make multiple unit restorations and they're on a cone connection, then we have very little give in the system. So sometimes we get around it by using other components again, which is like an intermediate opponent. Does anyone know what that's called? A multi-unit abutment. Yeah. So effectively we're turning a conical implant into a very simple to use, like a reverse cone with a hex on the top. That's what a multi-unit abutment usually looks like. And most systems have multi-unit abutments. In fact, the multi-unit abutments are almost identical, apart from the screw size, between most implant systems. So the system we use for full arch restorations, I just changed the screws and we use, it's called a Nexus system. We use the multi-unit abutments depending on what type of implant it is. So that's what I was trying to explain. Yeah, and there's lots of different connections, but those principles still hold true for what we're trying to do there. This is a slide just to show, sometimes you have a cobalt chrome denture where you put it in and it's almost seated but doesn't quite seat, and then in a short period of time it'll seat in place because the teeth adapt a little bit. Same with bridges. With bridges, we often even use a little non-rigid connector to account for the movement of teeth. We don't do that with implants because implants don't move. But it's got to be more accurate and put in place in its final space. Now the next step of complexity is talking about extended span bridge crack. So more than just 3 teeth, like more than 2 implants with 3 teeth. That's a short span bridge. This is an example. Here. So this is an example. Now this is an interesting picture. What's interesting about that picture? What's unusual compared to a normal OPG?
Staples.
Yeah. What do you think they are?
They had surgery before.
Yes. Yeah. So what are the staples used for in surgery, do you think?
Like to staple arteries.
Yeah, so they're called vascular clips. Yeah. So this was a cancer patient, and she had a resection. So this looks unusual, doesn't it? She had a resection from here to here, floor of mouth and tongue with a reconstruction. So when you look in her mouth, what you see is, there's 2 ways to do it. One is they close the gap, but in that case the tongue is kind of tethered to the, almost the cheek. Yeah. Or they use an intermediate graft, which is what they've used here, which is like a skin graft. So they take a paddle of skin plus the vessels, and they put it in the mouth and they plumb the vessels into the other vessels in the mouth. It's quite interesting stuff. So here we've got implants which emerge through skin, like hairy skin. So it looks like the skin of the arm, which is where the skin came from, but the implants emerge through it and we're building a bridge on top of those implants. So the design is a bit different. But out of interest, we're talking about an extended span bridge here. And it's getting a bit more complex than the simple, the 3-tooth bridge we spoke about before. Because as we get more implants, working at the level of the implant and trying to get either round corners or with multiple implants together gets quite difficult and is uncomfortable with the patient and hard to get accurate. So that's when we use these things called abutments. So these are multi-unit abutments. So this is 2 brands. Actually, this is an older slide. So that's a different kind of multi-unit abutment. Ignore that one. This is an Astra one, where it fits inside the implant and builds it up, and it's got a separate screw that fits on the top. I might have another picture. There we go. These are the more common ones. So these are called multi-unit abutments. They fit inside the implant to there, and then it builds it up. So it becomes a really easy to use connection at the gum level. So in this patient, I'm not worried about disturbing the skin graft and mucking around at the implant level. I bring it up to tissue level, and then I'm working on it there. And then these abutments stay on. So there's 2 types, there's straight ones, or there's angled ones. The angled one means that the implant's at this angle, but the restorative abutment goes at that angle. So, and all on 4, when they tilt the distal implants, we'll often use angled abutments to correct that angle and bring it back to being straight. So this is the difference in the process. These are the implants. They're the impression copings. This is a radiograph to check that they're seating in place. But then we decided we wouldn't do it like this, so we put abutments on. So here we've got that part is what we call a multi-unit abutment, and there are 3 of them. And then we've got different impression copings, 1, 2, 3, that fit on top of those multi-unit abutments. So it's got 2 screws, one that screws down here, and the other one that screws up here. So the smaller screw, the prosthetic screw, is the one that holds the prosthesis on. And those multi-unit abutments never come off. Now, if we're going, where are we up to? 10:30, yeah. So to take that to the next stage, is if we've done a longer span bridge, the next stage is a full arch bridge, or an edentulous patient. The challenges here, the additional challenges, are that we're replacing now pink and white tissues. So it's not just teeth, usually it's teeth and gum. We can make it in different materials, so we can make it in titanium acrylic or zirconia with titanium bars, and we can do things that are removable or fixed. But the challenge is usually we're making quite big things, and we've got to make sure that they're cleansable so that they last a long enough time. The other big challenge when you're doing a edentulous patient is you don't have any references, there's no teeth anymore. So where to position the teeth to make them look right, bite right, and take your records is an additional challenge. And the final one is that when you don't have any teeth, the patient doesn't have proprioception with their mouth. Sorry. So that means that, especially in the initial phase, they're more likely to break things. Has anyone had that experience? Nothing worse than putting a nice, beautiful full arch bridge in for a patient, and then they'll come back in a short time later and they've chipped something because they haven't yet developed the feeling for how to use it. Yeah. Teeth have that feeling straight away. So if you do work on teeth, generally people adapt straight away. But implants, especially fixed implant restorations, that takes time for the brain to understand. So when you use a removable prosthesis, the advantages are that it's easier to clean. You can take it out, clean it on the bench, put it back in. I saw a patient yesterday who's got quite advanced Parkinson's, and he couldn't keep his teeth because he had an unmanageable dentition. So we took his teeth out, and now he's got a complete upper denture and a clip-on lower denture. And that's thought to be, the clip-on lower denture is thought to now be the minimum standard of care that we use for edentulous patients. Has anyone heard that discussion before? The McGill consensus, it's called. So look it up, because it's worth knowing. McGill is a university in Canada. So the consensus statement is that complete dentures, or transitioning someone who is dentate to being edentulous, we try not to take them to a complete upper and a complete lower denture. Because what typically happens is they don't wear the lower denture. If you go to a nursing home, A lot of patients that are edentulous, probably less than half of them actually wear the lower denture. It affects the quality of life. So they're saying that a really cost-effective way of solving that problem is a 2-implant clip-on overdenture in the mandible. And the studies show us that the improvement in quality of life in doing that for a patient is enormous. So what they're saying is that the first port of call for someone who are transitioning to be edentulous, rather than being complete dentures, should be a complete top denture, which works better because it's got suction and better reference points, and a clip-on lower denture. So that's what we made for this gentleman. Now he had a lot of trouble cleaning his teeth before, but even with his hands shaking, he can take the dentures out, he can scrub them and put them back in. So that's a maintainable thing for someone who has limited dexterity or needs assistance in care. Removable prostheses are usually more cost effective. They're easier to control lip support. It's easier to hide the transition line. Transition line means the junction between the prosthesis and the natural gum. If you're doing a fixed restoration and it's pink porcelain and then gum, you don't want to see the join between the two. That's called the transition line. And speech is sometimes easier with a removable prosthesis, but the big factor is the maintenance is easier. So if something happens to this, he can come in, drop it off, go for a coffee, we repair it, he puts it back in. Whereas something that's fixed is quite a more complicated process. The difficulties are, we can't do it in ceramics, so they have to be done in acrylics. Ideally it's removed at night. Now people don't necessarily like that. And there's a psychological component to removing the teeth, having removable teeth. So this is an example of a bar overdenture. This patient has 4 implants and then a bar, locators on the bar, and then a separate prosthesis that clips over the top and clips onto those locators. The prosthesis looks like this. So these are so solid that they feel like a fixed prosthesis, except with force he can remove it at night time to clean it. They work pretty well for a patient where you've got to make a removable prosthesis. You can do it just with implants and locators on the top, but my experience is that patients tend to overload these. So they last for 5 years or so, and then they start to loosen the implants because there's more force on them, especially someone with Parkinson's or a movement type disorder. That's a slightly simpler way of making these things. It's just a cobalt chrome framework and locator or clip-on abutments. But the implant outcomes aren't quite as nice as if you have a bar in these prostheses. And then we have patients that are fully edentulous and we're looking at fixed restorations. So in the hierarchy of simple to complex, this is the more complex. The challenges with a fixed restoration is that there's always this balance between cleansability and the appearance. We can't put a flange on a fixed one because you can't clean underneath it. It's got to be round underneath. We've got to manage the transition, so usually they'll have an immediate first and then a final restoration later. There's more maintenance, more material costs, and breakages can be an issue with these sometimes. But that's an example of a fixed restoration. Again, that's from a while ago. This was a lady who had quite severe loss of lip support, and in the end we looked at removable prostheses for her because we couldn't get enough lip support with a fixed prosthesis. So maintenance is something we always discuss at the start, but it's something that is a really big component with implants and something patients need to be aware of, that they take ownership of the implants and it's got to be maintained really well over time. That's brushing the outside inside, fixed brushes underneath the prosthesis, super floss, and a water jet. And we use various combinations of those depending on what we're trying to do. So, how do we get the time? Go about 10 minutes. Does anyone have any questions about anything so far?
Excuse me, for the early failure,
Yeah.
do we just put bigger implants, or we have to graft and wait 3 months?
You've got to wait. So if you have an early failure, it's risky to take the implant out and put another implant straight in. So we take it out, treat it like an extraction socket, let it heal, and then put an implant in. Takes longer, but it's not worth putting another implant straight into a failed site. Yeah. So I'll talk a little bit more about fixed appliances for a second here. The reasons that they're complex, one is that you're working in a site that's just had surgery. So usually we try and immediately load these days, which means that teeth come out, implants go in, bridge goes on, all within a couple of days. The protocol usually is that I go to theatre with the surgeon, we have it all pre-planned, we have the prosthesis kind of pre-planned and designed, we have guided surgery, implants go in, I take the scans while the patient's under general anaesthetic, they go home and chill out for 2 days, and then they come back to my rooms and I'll fit the bridge a couple of days later. So that means that's much better than having a denture over the extraction wound sites. Because this was an example of an old case where we did it the traditional way, which is implants go in, and then, this is actually when I was a postgrad, we were monitoring the healing just by keeping an eye on it, and she was wearing a denture over the top. But it takes quite a long time before someone can comfortably wear a denture over the top of implants. I'm also worried about the denture pressing on the implants. So we don't do it like this very often anymore. We prefer to have them immediately loaded. When you do fixed implant restorations, you do a lot more complicated componentry. And we need to think about things like cantilevers. Now this was, when I took this bridge off, this was the cleanest gum I've ever seen under a fixed implant restoration. I had to take a photo. This guy was the best cleaner that I've seen there. Usually there's a little bit of inflammation, but you can see how pink and healthy that tissue is there. But we placed the implants, so this is his OPG. We placed the implants in the anterior mandible, not in the posterior mandible. Why do you think we do that? And we have a cantilever, it's extended back from those implants in the anterior mandible.
Because of the anterior loop.
The whole nerve, yeah. So the nerve comes down here and comes down here. So usually you can't put very solid implants in the posterior mandible. But we know that the bone in the anterior mandible is the best bone in the body to put implants into. It's solid and strong. It actually doesn't, you know, we're talking about growth. The growth of that part of the mouth finishes when someone's about 10 or 12. So for ectodermal dysplasia patients who don't have any teeth, we'll often do implants there when they're in their teenage years. And it's very strong, and we can definitely cantilever distally from anterior mandibular implants. There's talk about flexure of the mandible as well. So when you open and close, the mandible actually changes its shape a bit. And if you have implants right around the arch, then that's thought to decrease the success of posterior implants. But the biggest factor with fixed implant restorations is this proprioception idea, or the patients tend to break them, which is frustrating if you've kind of made this beautiful full arch bridge and then they break it like that. This is another example. I'd actually give lots of examples of a case with a problem. What do you think the problem is here? Can anyone see? So firstly, there's obviously implants in the anterior mandible. One of them is so deep and not in a very good position that I'm going to cover that up and bury it. That's this one. Ignore that implant. What else have we got here? We've got 5 implants. What's on top of them? Impression curtains, right. So why do you reckon I've taken this X-ray? We've spoken about it before, yeah.
Check the position.
Say it again?
Can you check the position of the impression curtain?
Yes, what am I looking for?
Is there a gap between
Yes,
the impression
perfect. So we're looking to see whether they're seated. Are they all seated?
curtain? No.
This one's not, is it? Yeah. So imagine if you hadn't taken this X-ray and you made a full arch bridge and went to fit it, and you found that it didn't sit on that implant. That'd be a disaster, wouldn't it? Yeah. So that's why we take the X-ray. It's worth taking the X-ray to know that everything seated in place, and then it's our check before we move to the next step. Especially on X-Hex implants like this, they've got a fiddly connection that's it's sometimes easy to think they're seated when they're not actually seated. And so what have I made there now? So obviously I repositioned that coping and went through the process of making it. But what do you think is happening now? What's the construction? Any idea? Yeah, so it's a milled titanium bar, and then we'll have acrylic teeth over the top. You can just make out the outline of the acrylic. But we have implants. These are old implants. They've been there for 40 years or something like that. And we've remade the prosthesis on the top and got rid of the one that was causing the problem. And then we have patient risk factors, which I'll run through quickly. Patient or medical risk factors can be medical things. There's this thing called the ASA, or the anaesthetic scale of risk. And if patients are above a certain level, then we don't usually treat them with this kind of management strategies. So what we're asking in real terms is, can the patient be safely treated in the dental chair? Or do we need to modify the plan to accommodate for their medical issues? We're asking what the prognosis of the dentition is, and does the medical status affect that? Should we do something differently with their teeth? An example of that might be, we had a patient recently who had a scleroderma. Does anyone know scleroderma? Yeah, scleroderma is an autoimmune condition where they get fibrosis of the mouth gets smaller, but they get really severe xerostomia and reflux. What do you think xerostomia and reflux might cause? Caries, yeah. So they lose their teeth, it gets really hard to manage. We can't have you have access problems. So sometimes there's a window as they're developing this condition where we can treat them. But are we going to keep teeth that are dodgy? No, because those risk factors are too high for that, aren't they? So in that case, we're more likely to take teeth out, do some implant dentistry, and do it in the window before the condition progresses further. And then the big thing that I've asked myself is this patient well managed medically? Because sometimes we talk about things like uncontrolled diabetes. Obviously, we want to manage the medical status to improve the dental status. So we want to have them healthy enough that we can predictably manage their dental status. We have issues with age and mobility. We're asking, can the patient tolerate extensive dental treatment? Can the patient maintain the treatment? Are there carers that need to help? If there are carers that need to help, then removable prostheses that the carer can help with cleaning works very well. And especially in young patients, there are social implications for removable teeth or missing teeth. We're talking about things like bisphosphonates these days. I think everyone's very aware of bisphosphonates now. The idea of bisphosphonates is they stop the cells that take away old bone. So it means that when you take out a tooth or put an implant in, you need to take away the old bone before you put new bone down. And sometimes it doesn't heal properly. And it's not an absolute contraindication for implant treatment, but it's something that kind of we manage very carefully. This was an example. This was a lady who had a very sharp ridge posteriorly, and we made her a denture. And then she was crossing the road and fell over, and she was getting into the steps of a bus and fell over and whacked her head. And developed this sinus, this weird sinus in the ridge under her denture. So this is me putting a GP point into the sinus because I thought it was from the teeth. But obviously it's not going to the teeth. And if you look really closely in retrospect, you can just see that there's like a weird line. That was when I first took the X-ray. There's a bit of a weird line down here. And then this part of the ridge became necrotic. So it looked like this. And then the surgeon opened it up, cleaned it all out, stitched it all back together, got rid of the problematic area, and it went away. But she was on a bisphosphonate medicine. I don't think it was the accident. I think the accident triggered it, but I think it was the bisphosphonate medicine that caused this osteonecrosis type problem. Radiation obviously gets more complicated. We're talking about cancer patients there. Growth status is another risk factor for placement of implants in the anterior maxilla. We spoke about that earlier as well. And you can see that the growth, even though these orthodontic charts only finish at 18, some of them aren't flat. So on the growth status here, when it finishes, it's flat. But at 18, a proportion of people are still tapering down into this area, and they'll grow off and on. It won't be a linear growth pattern. So if you place implants too early, then there is a risk of infraposition at those stages. Because obviously the face grows over a long period of time. Cool, we might stop there because I think it's morning tea time. And I've got a couple more slides and then we'll go on to the demo shortly after. So come grab a cup of tea.